Okay, hello everyone. This recording is going to be about Guillain-Barré syndrome. This is an autoimmune disorder. Okay, Guillain-Barré, it's what will be classified under polyneuropathy, meaning that there's an infection process that cause eventually lead to neuropathy, meaning degenerative demyelination of the nerves, again, just like multiple sclerosis. So, Guillain-Barré is causes ascending paralysis. Again, it's an autoimmune issues. You have some type of infection process, and later on, that infection, the pro-inflammatory markers that are released start attacking the myelin sheath and demyelinating the myelin sheath, especially the myelin sheath is of the periphery. The thing with Guillain-Barré is that demyelination starts with the lower extremities and slowly ascends to the upper or to the torso area, to the respiratory muscles. It's a nerve problems. Um, Main future, again, it can be acute in nature, ascending, progressive, symmetric weakness of the limbs, and go down from there. Okay. Okay, Guillain-Barré, it's what will be classified under polyneuropathy, meaning that there's an infection process that causes. Um, okay, Guillain-Barré, it's what will be classified under polyneuropathy, meaning that there's an infection process that cause eventually lead to neuropathy, meaning degenerative demyelination of the nerves, again, just like multiple sclerosis. So, Guillain-Barré is causes ascending paralysis. Again, it's an autoimmune issues. You have some type of infection process, and later on, that infection, the pro-inflammatory markers that are released start attacking the myelin sheath and demyelinating the myelin sheath, especially the myelin sheath is of the periphery. The thing with Guillain-Barré is that demyelination starts with the lower extremities and slowly ascends to the upper or to the torso area, to the respiratory muscles. It's a nerve problems. Um, Main future, again, it can be acute in nature, ascending, progressive, symmetric weakness of the limbs, and go down from there. Okay. Um, Risk factor could be immunization, for instance. Sometimes patient will start having the Guillain-Barré attack after getting the flu shots. We've had some patients who had COVID, the COVID immunization, and then got Guillain-Barré after that, or some type of gastroenteritis. Stomach flu is gastroenteritis, or some cytomegalovirus, or you have a Campylobacter jejuni, for instance. Um, the immune system that is being elicited is going to lead to edema, inflammation, and later on is going to cause the demyelination of the neuron. Okay, some of the clinical manifestations are pain, right? Neural pain, tingling, numbing, paresthesia, hypotonia, areflexia, meaning a difficulty, no reflex. You have weakness. You have you can have bowel and bladder control. Um, issue with bowel and bladder control with this as well. And what else? You can have paresis and later on paralysis. Well, of course, it's going to be progressive. Uh, a lot of the time, patient with Guillain-Barré will show up with paralytic ileus, muscle atrophies, and obviously, if they're not moving, they're prone to VTEs, pressure ulcer, and orthostatic hypotension and so forth. Symptoms usually will progress rapidly, and but over a couple of weeks or so. But again, generalized weakness and then difficulty with movement, and then you have the paresthesia, the tingling, the numbness, and then later on you have the paralysis. So the patient will come in and say, "I'm so tired," or "I'm having difficulty walking." And then I'm having difficulty breathing. At that time, they're barely like they're unable to speak. Even at that time, they might end up intubated. Again, diagnostic studies. The diagnostic study for Guillain-Barré, it's not it's very difficult to diagnose somebody early. It's based on CSF analysis, and it takes about a couple of weeks for you to get final diagnosis. So again, the presentation may resemble other chronic neurological issues that patient may have. Myasthenia gravis, um, multiple sclerosis, and so forth. So again, the presentation is the same. The pathology is infectious base, and it's progressive in nature. So basically, they will do with any of those neurological symptoms presentation. They're going to obtain an LP, and then they also can do a muscle conduction testing, like what you see in these pictures. And they'll try to rule out, again, it's a diagnosis of exclusion. They might do an MRI to rule out MS, right? Because in MS, you have to have pathology in two different places, like plaque deposition in two different places, and you have to have the weakness and in addition to the presentation. So once the CSF analysis return, it will take about 2 weeks. It says 7 to 10 days. So really, the true diagnosis of Guillain-Barré is the rise in protein in the CSF. Okay. The goal is to prevent any respiratory or to have respiratory support for the patient because it's ascending paralysis. The complication is respiratory in nature, and we want to maintain hemodynamic. As far as treatments, what I have seen, since they don't really know what you have. Now, the books say the management of Guillain-Barré is the use of plasmapheresis, which I agree. However, when you present, for the first time with Guillain-Barré, it's the diagnosis of exclusion. So usually the process is you're given an IVIG, or sometimes you're given a high dose of steroid for like 3 days. And if that doesn't work, then they give you IVIG. Now we're a little bit quick to give IVIG. Then they can give IVIG for 3 to 5 days or even 7 days. And then if that doesn't work, then they can say, oh, okay, now we can give plasmapheresis. But in order to stop the inflammatory process and to stop the demyelination, plasmapheresis needed to be uh, to to start early, but that's not always the case. Plus, you have to think about smaller hospitals; they don't have the um, capabilities, right? To have plasmapheresis in place. They don't have a dialysis in the department. They don't do their own dialysis, or they don't do their own plasmapheresis. So they have to outsource a company to come and do the plasma exchange for them. So that process may also delay treatments. So again, the longer you delay treatment, the more paralysis, paresis the patient is going to exhibit. All right. So once plasmapheresis is started, first of all, you need to know the IV nursing management for a patient receiving IVIG. If you don't already know that, um, medication needs to be monitored. You have to give pre-medication before you give it, and it has to be titrated to whatever the rate is going to be until it is finished. And we can further discuss this in class. Plasmapheresis also, just like dialysis, really what it's doing is going through it's yeah, it's almost like dialysis, but it's kind of removing the inflammatory markers, the white blood cells, the leukocyte, the excess of it from the plasma. So some of the complication of that can be hypotension, which is the same for dialysis. Whenever you take a large amount of volume or a percentage of blood volume and put it through a machine, the patient has less blood for cardiac outputs. Therefore, they might exhibit some symptoms of that. And then citric toxicity, which I will talk about in class. Nursing management, in addition to neurological assessment, um, obviously we need to again manage respiratory status, provide physical um, therapy. We need to monitor vital capacity. So if you have to monitor ABG, it depends on where the patient is and what the patient is doing. If the patient is on events, you guys already know everything you need to monitor for a patient who is on event, for instance. Um, if the patient start to develop, when it says here fever develop, meaning that you can get infection when you're on event, then you start antibiotic therapy. We also want to make sure that the patient, we are meeting the nutrition um, needs for the patient by initiating enteral nutrition early during the process. Early mobilization is key to recovery. I know you say most patients recover spontaneously at about 28 days. I've seen patients months post. When they say recover spontaneously, they don't mean full recovery here. Maybe you can walk now, but patients sometimes still have like some weakness for months. I've seen somebody who have weakness 7 month post, 9 month post, still who hasn't fully recovered. So again, the recovery process will start, but it doesn't mean that you're fully recovered. Again, it depends on the situation and depend on the patient. Yeah, that's all she wrote.